Okay, well, I think that if you go by the evidence on volume-targeted ventilation, you have all the support to use volume-targeted because, again, the suggestion is that you can reduce duration of ventilation and that you can maybe reduce bronchopulmonary dysplasia. As I mentioned, we are not convinced about the strengths of the evidence on BPV. And on the other hand, we have been using targeting for more than 20 years. We actually helped some of the companies to develop volume targeting, and Dr. Gerhardt was part of our members. So it's not that we are uncomfortable because we don't have experience. We are uncomfortable because every time we use it, we see that it's a strategy that requires much more knowledge, much more certainty in terms of what each ventilator. We don't have time to go into that, but there are all sorts of different algorithms, different systems that produce volume targeted. None of these things have been evaluated in any systematic way. So we are very worried. And again, the first equipment, what algorithm the equipment is using, accuracy of the flow sensor are crucial. If those things are not working, it can do much more harm than good. And the main limitation in our judgment is what tidal volume do you use? If you are targeting a tidal volume that is insufficient for a certain patient, what happens? The baby will start making more effort, will move a tidal volume larger than the one you are setting, and the ventilator will win the pressure completely because we'll think that the baby is getting a tidal volume that is excessive. So you are targeting 5. This is a chronic lunger who needs a tidal volume of 6 or 7. He increases his effort to get that 6 or 7, and the peak pressures are win. So this is, and you see the baby struggling, okay, to breathe. All the effort has been essentially passed to the baby. No good situation. I think it's very good. It's very poor. Now the other side is that if you are using a tidal volume that is higher than what the baby requires, usually you will lower the CO2 below the apneic threshold, essentially. The baby will be very happy, will not be breathing because he will be getting a tidal volume that is higher than what he is set for. And essentially, you are passing all the responsibilities to the ventilator. We see this happening all the time in our own unit with patients. And the tidal volume that now may be 5 or 6, tomorrow may be 7 or 4, what the baby needs. These are dynamic changes, as Dr. Gibbs explained very nicely. So it requires much more knowledge, much more being on top and perfect equipment to achieve this. And we feel that this is not easy to achieve in most neonatal ICU. So that's why we don't use it routinely on everybody.